If you determine that your patient does not have a patent airway, you must take action to secure it. The airway must be maintained throughout all care procedures. The most common impediment to an open airway is a lack of airway muscle tone. When a patient becomes unconscious, the muscles relax. The tongue and tissues of the larynx will slide back into the pharynx and obstruct the airway. Even though a head tilt chin lift or jaw thrust maneuver will help open a patient's airway, the obstruction may resume once the maneuver is released. Sometimes, even when the head tilt chin lift or jaw thrust is maintained, soft tissues and the tongue may continue to partially obstruct the airway. Airway adjuncts, devices that aid in maintaining an open airway, may be used to initially assist in the opening of an airway and continually used to help keep an airway open. There are several types of airway adjuncts. The two most common airway adjuncts, whose main function is to keep the tongue from blocking the airway, are the oropharyngeal airway, also known as the oral airway or OPA, and the nasopharyngeal airway, also known as the nasal airway or NPA. The structure and use of these airways can be understood by analyzing their names. Oro refers to the mouth, naso to the nose, and pharyngeal to the pharynx. Oropharyngeal airways are inserted into the mouth and help properly position the tongue. Nasopharyngeal airways are inserted through the nose and rest in the pharynx, also to help properly position the tongue. Rules for using airway adjuncts. Some general rules apply to the use of oropharyngeal and nasopharyngeal airways. Use an oropharyngeal airway only on patients who do not exhibit a gag reflex. The gag reflex causes vomiting or retching when something is placed in the pharynx. When a patient is deeply unconscious, the gag reflex usually disappears, but may reappear as a patient begins to regain consciousness. A patient with a gag reflex who cannot tolerate an oropharyngeal airway may be able to tolerate a nasopharyngeal airway. Open the patient's airway manually before using an adjunct device. When inserting the airway, take care not to push the patient's tongue into the pharynx. Have suction ready prior to inserting an airway. Do not continue inserting the airway if the patient begins to gag. Continue to maintain the airway manually and do not use an adjunct device. If the patient remains unconscious for a prolonged time, you may later attempt to insert an airway to determine if the gag reflex is still present. When an airway adjunct is in place, you must maintain the head tilt chin lift or jaw thrust maneuver and monitor the airway. After an airway adjunct is in place, continue to be ready to provide suction if fluid such as vomitus or blood obstructs the airway. If the patient regains consciousness or develops a gag reflex, remove the airway immediately. Use infection control practices while maintaining the airway. Wear disposable gloves. In airway maintenance, there is a chance of a patient's body fluids coming in contact with your face and eyes. Wear a mask and goggles or other protective eyewear to prevent this contact. Oropharyngeal airway. Once a patient's airway is opened, an oropharyngeal airway can be inserted to help keep it open. An oropharyngeal airway is a curved device, usually made of plastic, that can be inserted into the patient's mouth. The oropharyngeal airway has a flange that will rest against the patient's lips. The rest of the device moves the tongue forward as it curves back into the pharynx. There are standard sizes of oropharyngeal airways. Figure 9.6. Many manufacturers make a complete line ranging from airways for infants to large adult sizes. An entire set should be carried to allow for quick, proper selection. The airway adjunct cannot be used effectively unless you select the correct airway size for the patient. To determine the appropriate size oral airway, measure the device from the corner of the patient's mouth to the tip of the earlobe on the same side of the patient's face. An alternative method is to measure from the center of the patient's mouth to the angle of the lower jawbone. Do not use an airway device unless you have measured it against the patient and verified it as being the proper size. Remember that if an airway is too big, its distal tip will rest close to the esophagus and direct air into the stomach. If it is too small, it will not properly displace the tongue forward to open the airway. If the airway is not the correct size, do not use it on the patient. So again, to measure it, to determine the appropriate size oral airway, measure the device from the corner of the patient's mouth to the tip of the earlobe on the same side of the patient's face. So I think that means like hold it up against the patient's face and look at it, but I would get clarification on that. To insert an oropharyngeal airway, follow these steps in scan 9-2. Place the patient on his back and use an appropriate manual method to open the airway. If no spinal injuries are to stop for a second, you might want to flip to the page with 9-2, with scan 9-2. Here, you look at this page while I'm reading. Place the patient on his back and use an appropriate manual method to open the airway. If no spinal injuries are suspected, use a head tilt chin lift maneuver. If there are possible spinal injuries, use the jaw thrust maneuver, moving the patient no more than necessary to ensure an open airway. The airway always takes priority over the spine. Perform a crossed finger technique to open the mouth. That is, cross the thumb and forefinger of one hand and place them on the upper and lower teeth at the corner of the patient's mouth. Spread your fingers apart to open the patient's jaws. 3. Position the airway device so its tip is pointing toward the roof of the patient's mouth. Insert the device and slide it along the roof of the patient's mouth, past the soft tissue hanging down from the back, the uvula, or until you meet resistance against the soft palate. Be certain not to push the patient's tongue back into the pharynx. Any airway insertion is made easier by using a tongue blade or a tongue depressor, or a rigid suction tip to assist in moving the tongue forward. In a few cases, you may have to use a tongue blade to hold the tongue in place. Watch what you are doing when inserting the airway. This procedure should not be performed by feel only. Gently rotate the airway 180 degrees so the tip is pointing down into the patient's pharynx. This method prevents pushing the tongue back. Alternatively, insert the airway with the tip already pointing down toward the patient's pharynx, using a tongue depressor or rigid suction tip to press the tongue down and forward to avoid obstructing the airway. This is the preferred method for airway insertion in an infant or child. Position the patient. Place the non-trauma patient in a head tilt position. If there are possible spine injuries, maintain cervical stabilization at all times during airway management. Check to see that the flange of the airway is against the patient's lips. If the airway device is too long or too short, remove it and replace it with the correct size. Monitor the patient closely. If there is a gag reflex, remove the airway adjunct at once by following the anatomic curvature. You do not need to rotate the device when removing it. Note, some EMS systems allow an oropharyngeal airway to be inserted with the tip pointing to the side of the patient's mouth. The device is then rotated 90 degrees so its tip is pointing down the patient's pharynx. Use this approach only if it is part of the protocol of your EMS system.